Good morning, class. The topic for today is type 1 hypersensitivity reactions. It is also called as anaphylactic reaction. The contents of this today's class are the mechanism of anaphylaxis, systemic and local anaphylaxis, anaphylactoid reactions, and conclusion. Now, what is a hypersensitivity reaction? Immune responses to antigens of their either endogenous or exogenous origin, causing tissue damaging reactions. The resultant tissue lesion is called as hypersensitivity disease. Now, type 1 hypersensitivity reaction or anaphylactic type is a rapidly occurring reaction that follows the combination of an antigen with an antibody previously bound to the surface of mast cells and basophils. And what is allergy? Allergy is an altered body reaction, usually a hypersensitivity reaction as a response to exposure to a specific substance. Now, the main components of type 1 hypersensitivity reactions are mast cells, basophil cells, and immunoglobulin E antibodies. So, starting with the first important component of type 1 hypersensitivity reaction, the mast cell. They are bone marrow derived cells. They are found predominantly near the blood vessels and nerves and in the subepithelial sites. This is a mast cell which contains the receptor for immunoglobulin E, and these are the granules. After the antibody attaches itself to the receptor, it is called a sensitized mast cell. When an allergen, a body is exposed to an allergen, the allergen links the immunoglobulin E antibodies, which causes the granules to release the biologically active mediators like histamine and leukotrienes, which then cause a response, a systemic or local response. The second most important cell is the basophil. It is similar to the mast cell. In the presence of cell surface IgE Fc receptor, these are the receptors, and it has cytoplasmic granules which release the mediators. But in contrast to mast cell, it is not normally present in the tissues, but rather circulate in the blood in extremely small numbers. It can be recruited to the inflammatory sites when required. This is again an allergen, which is cross-linking the IgE antibodies, which leads to the release of biologically active mediators from the cytoplasmic granules. Third important is IgE antibody. The half-life of IgE antibody is 2 days. It is heat labile. It has affinity for surface of tissue cells, particularly the mast cells, which has the IgE receptors. It has greatly increased serum levels, is seen in allergic conditions, and it has an unidentified role against intestinal parasitic infections. Now, this is again the first exposure to an allergen stimulates the B lymphocyte, which in turn stimulates the plasma cells to release IgE molecules. They attach the on the Fc receptor on the surface of the mast cell, and these are the granules which are then released when the mast cell gets sensitized. Now, the mechanism, what happens in anaphylaxis is when a body comes in contact with an allergen, the T lymphocytes are activated, which in turn activates the helper T cells, and with the help of other interleukins, the plasma cells produce IgE, that are the allergen-specific IgE antibodies. These then attach to the receptors on the surface of the mast cell. And when the body again comes in contact with the allergen, this process is called sensitization. When for the second time the body comes in contact with the allergen, the cross-linking of the antibody takes place, and the granules are released. The biologically activated biological mediators that are released are histamines, leukotrienes, cytokines, prostaglandins, which then cause the local symptoms like swelling, itching, nausea, vomiting, diarrhea, or the systemic symptoms like airway obstruction, hives, blood pressure drops, and arrhythmia. So this is what the first exposure of allergen, and this is the second exposure of allergen, which is causing the allergic reaction or the hypersensitivity, anaphylactic reaction. Now, how is the activation of the mast cell happening, and how are the mediators released? Now, there are primary mediators and secondary mediators. So when the antigen is coming and cross-linking the IgE, immunoglobulin E antibodies, which are already attached to the receptors on the surface of the mast cell, it signals the degranulation process, and the granule contents are histamine, proteases, and chemotactic factors, which causes the initial response. These are the primary mediators. Now, also, the secondary mediators are released, or they're synthesized by the cell. What happens is this signal for the activation of phospholipase happens when the antigen is attached. This signals the cytokine gene activation, which then finally secretes the cytokines. Also, the membrane phospholipids help in the secretion of arachidonic acid, which in turn forms the secondary mediators leukotriene and prostaglandin, which cause a late phase reaction. So these are the primary and the secondary mediators which are released when the mast cell is activated. So these are the action of mediators. All them primary and secondary mediators that are released, like TGF, beta, and FGF, they act on the fibroblast, which helps in the wound healing and fibrosis. Histamines and proteases act on the nerve cell and smooth muscle cell, and which affect the neuroimmune interactions, peristalsis, and bronchoconstriction in pain. Then the various types of interleukins act on the T cell, B cell, and eosinophils and help in the immune cell recruitment and activation. The histamines and heparin acts on the blood vessel endothelium and regulate the blood flow, coagulation, and vascular permeability. The tumor necrosis factor acts on the neutrophil and is responsible for the immune cell recruitment and activation. And the histamine and prostaglandins that are released affect the secretion and epithelial permeability. So there's an initial and a late phase. The initial phase reaction is caused by the primary mediators, which are released by the same process, the mechanism that I showed earlier. When the antigen causes cross-linking of the IgE antibody, the mediators are released, and it causes an initial reaction, which is vasodilation, vascular leakage, and smooth muscle spasm. These are the primary mediators. So these are the effects of the primary mediators: vasodilation, vascular leakage, and smooth muscle spasm. And in the late phase, and also by the secondary mediators, what happens is mucosal edema, mucus secretion, leukocyte infiltration, epithelial damage, and bronchospasm. Now, anaphylaxis can be of two types: systemic and local. Systemic anaphylaxis follows an intravenous injection of an antigen or a direct administration of an antigen into the circulation to which the host has already been sensitized. Whereas within minutes of exposure to an antigen systemically, a state of shock can be reached. Whereas in local anaphylaxis, it depends on the portal of entry of an allergen. So this is skin contact, This is a local anaphylactic reaction like poisonous plants, animal dander, pollen, or latex gloves. Injection, which is systemic anaphylaxis shock, is caused by bee sting or a medication. Ingestion may cause anaphylaxis reaction like a medication or nuts and shellfish. And inhalation can cause like pollen, dust, moles, and animal dander. These are the modes by which allergic reaction can be caused: a skin contact, injection, ingestion, and inhalation. Now, the severity of this systemic anaphylactic reaction varies with the level of sensitization. Administration of hormones, enzymes, bee sting, and drugs can cause a systemic anaphylactic reaction. The initial exposure or the first dose causes is called a sensitizing dose, and it causes sensitization. The subsequent exposure or the second dose is called a shocking dose, and in this, the allergic reaction is sudden, severe, and involves the whole body. The signs and symptoms of systemic anaphylactic reaction are: on the skin, there is a generalized swelling seen. In the body, there's itchiness, flushing, swelling of lips, tongue, and throat. On GIT, there is cramping, abdominal pain, diarrhea, and vomiting. The respiratory effects seen are shortness of breath, wheezing, laryngeal edema, hoarseness, and laryngeal obstruction. Finally, the serious effects are coronary artery spasm and myocardial infarction. The central nervous system effects signs seen are decrease in the blood pressure, which leads to loss of consciousness, loss of bladder control and muscle tone, and feeling of anxiety. Shock, a state of shock can be reached, and even the patient can die within the hour unless treated with epinephrine. Now, insect sting or a bee sting is a type of systemic anaphylaxis. What happens is the bee venom penetrates the skin and enters the bloodstream, as you can see here. Now, the bee venom cross-links the IgE antibodies. The mast cell already has the receptors for the IgE antibodies. The antibodies for the bee venom are produced, and the bee venom cross-links these antibodies, and the mast cell releases its granules, which are the biological active substances. Now, what this causes, the circulatory system spreads the venom throughout the body, and this process takes place where the biologically active substances are released in the blood, and these causes the symptoms like dizziness, seizures, loss of consciousness. The lips, tongue, and throat can swell up and make swallowing and breathing difficult. Irregular heartbeat or a heart attack can occur, caused by a lowered blood pressure. Wheezing and other asthma-like symptoms can result when smooth muscle of the lower airway constricts. Cramps, vomiting, and diarrhea may arise from contraction of the smooth muscle lining the stomach and the intestine. Skin may become reddened, and rashes and severe itching may develop. So these are all the systemic symptoms. Now, drug allergy is also a form of systemic anaphylaxis, and the drugs that are commonly involved in causing an allergic reaction are penicillins, cephalosporins, sulfonamides, chloramphenicol. Drugs taken in heart conditions like ACE inhibitors, amiodarone, and methyltopa. Anesthetic drugs like muscle relaxants and halothane. Morphine derivatives like morphine, pethidine, and codeine. Aspirin-like drugs like diclofenac, ibuprofen, indomethacin. Cancer chemotherapy drugs like cisplatin, cyclophosphamide, and methotrexate. Antiseptics like chlorhexidine and iodine can also cause occasionally an allergic reaction. The vaccines have preservatives like paraben, anticonvulsant, antituberculosis medications can also cause an allergic reaction. Now, the manifestation of these allergic reactions are hives, skin rash, itching of the skin and eyes, wheezing, swelling of the lips. The diagnosis can be made by proper history. Although the patient at risk can generally be identified by a previous history of some form of allergy, the absence of such a history does not preclude the possibility of an anaphylactic reaction. A patch test should always be done prior to administration of any drug. The treatment involves immediate withdrawal of the suspected drug, antihistamines, corticosteroids, epinephrine, and immunotherapy. Coming to local anaphylaxis reaction, atopy. The term atopy, genetically determined predisposition to develop localized anaphylactic reaction to inhaled or ingested allergen. It is characterized by large quantities of IgE antibodies in the blood. So this is a localized reaction. Now this occurs when you inhale or ingest an allergen. This includes food allergies, hay fever or allergic rhinitis, asthma, urticaria, angioedema. Food allergies. Now, amount of food needed to trigger a reaction and symptom of allergy may vary from person to person. A protein in the food is the most common allergic component. These kind of allergies occur when the body's immune system mistakenly identifies a protein as harmful. Some proteins or fragments of proteins are resistant to digestion, and those that are not broken down in the digestive process are tagged by the immunoglobulins. Now, the etiology for food allergy can be ingestion of nuts. The common food allergens are nuts, shellfish, fish, milk, eggs. This is a list of the items people can be allergic to, and the chances that if they are allergic to one kind of nuts, they are allergic to the other kind of nuts as well. If the person is allergic to one kind of fish, the chances of him or her allergy to other kinds is 50%. In the same way, if the person is allergic to cow's milk, the chances of them being allergic to the goat's milk is 92%. So this is the list of the items and the risk involved of reaction to at least one or the other types of a food item. The manifestation are cardiopulmonary, GIT, and skin symptoms. They may progress to an anaphylactic shock. A local anaphylaxis reaction may also cause an anaphylactic shock if not treated. Hay fever or allergic rhinitis, as I said, inhalation or ingestion causes a local anaphylactic reaction. The predisposing factors are again the pollen, dust mite, or animal dander, which when inhaled causes symptoms like watery eyes, runny nose, and itchy throat. Now, the mechanism is when entrapment of pollen and digestion of the outer coat by the mucus and enzyme lysozymes releases a protein allergen. Now, initial interaction between the allergen and the tissue mast cell and then involve the perivenular mast cells, both of which are sensitized with specific IgE. The clinical response to inhaled allergen is quantitatively related to the naturally occurring pollen dose. What happens is the body produces antibodies which work to fight the trigger. Now, the antibodies attached to the allergy cells, these are the allergens, they attach and form the cross-linking, and this causes the allergic reaction by the release of histamines, which irritates the body, causes itching, swelling, tearing up of eye, wheezing. The manifestations are rhinorrhea, sneezing, obstruction of nasal passages, pruritus of conjunctiva, nasal mucosa, and oropharynx. In the nasal mucosa, it can be pale and boggy. The conjunctiva can be congested and edematous. There can be lacrimation, swelling of mucous membrane with obstruction of sinus ostia and eustachian tubes. This precipitates secondary infection of sinus and the middle ear. You can have postnasal drip as well. because there is inflammation of the lining of the nose. The diagnosis is accurate history. The serum IgE levels will be found to be increased, and a skin test or a patch test. Treatment: antihistamines, cromolyn sodium, glucocorticoids, immunotherapy, or hyposensitization can be done. Asthma is another form of local anaphylaxis reaction. The predisposing factors are again the pollen, dust mites, or animal dander. The symptoms are same like allergic rhinitis, watery eyes, runny nose, itchy throat. The mechanism, again, it's the same thing. The first exposure to the allergen leads to the stimulation of plasma cells to produce IgE antibodies, which attached to the surface receptors on the mast cell, which leads to the release of the granules, and they cause the initial reaction. When the body is exposed again, it causes the cross-linking of the IgE antibodies, and the mast cell degranulation releases histamines, leukotrienes, prostaglandins, and cytokines. Slow reacting substances of anaphylaxis causes bronchial smooth muscle spasm and wheezing. Asthmatic attacks are often preceded by allergic rhinitis and urticaria. The manifestations are, you can compare, this is the normal airway and this is during an asthma attack. The airway is narrowed, the muscles are tightened, and the thickened airway wall can be seen, and thick mucus secretion is seen. This is on the cross section. The airway wall is thinner here, whereas it's thickened, and thick mucus secretion is there, which makes it difficult to breathe. The symptoms are dyspnea, cough, wheezing, and the accessory muscles are active during this stage. The diagnosis can be made again on accurate history, and the serum IgE levels will be increased, and a skin test can be done. The treatment includes antihistamines, which decrease the effect because histamine does not appear to be the major factor eliciting the asthmatic reaction. Elimination of the causative agent is required. Immunotherapy or hyposensitization can be done. Epinephrine or isoprotenolol can be given. Aminophylline and theophylline can be given. Anticholinergics, atropine sulfate and epatropium bromide can be given. Glucocorticoids and cromolyn sodium are also the line of treatment. Urticaria and angioedema. They are both also a hypersensitivity reaction. Angioedema is characterized by edema of the superficial portion of the dermis in urticaria, and of subcutaneous tissue as well as the dermis in angioedema. Urticaria is just the edema in the superficial portion, whereas in angioedema, it is also of the subcutaneous tissue along with the dermis. Angioedema is also known as Quincke's edema or giant urticaria. The predisposing factor are inhalation or physical contact with the pollens, animal dander, fungi, food, dust, cold, heat, solar rays, mechanical irritation, and dermographism, that is appearance of linear wheel at the site of wrist stroke with a firm object. Pressure. Mechanism is marked mast cell degranulation in response to antigen with associated edema of dermis and the subcutaneous tissue as well. The marked rise in plasma content of histamine can be seen. The manifestation is wheal. There is a local circumscribed area of swelling of the skin due to increased local permeability of the capillaries. A flare. The wheal and flare regions are very common in urticaria. A flare is erythematous raised border surrounding the wheal. A wheal appears pale and the surrounding area is erythematous due to vasodilation. It is distinctly pruritic. It appeared in crops of 24 to 72 hours duration. It involves extremities of the face, with angioedema often being periorbital and in the lips. Angioedema of the upper respiratory tract can be life-threatening due to the laryngeal obstruction. And in GIT, it can cause symptoms like abdominal pain with or without nausea and vomiting. This is an urticarial region, wheal and flare lesion. The center part is the local circumscribed wheal region, which has increased permeability of the capillaries, and it causes swelling of the skin, surrounded by a flare due to vasodilation. These are called hives or an urticaria. This is angioedema involving the subcutaneous tissues as well, involving the lips, periorbital region. You can see the periorbital swelling. Again, a periorbital swelling in the tongue. Diagnosis is based on clinical history, skin testing, and an assay for allergen-specific IgE in the serum, which will be increased. The treatment is antihistamines and systemic glucocorticoids. Anaphylactoid reactions. Now, what are anaphylactoid reactions or pseudoanaphylaxis? It is similar to anaphylaxis, but it does not involve an allergic reaction. It has no immunological basis and is non-specific mechanism involving the activation of complement and the release of anaphylactoxins. Their release may be triggered by IV infusion of certain drugs like morphine and aspirin. Now, to summarize, the initial contact with the allergen stimulates the plasma cells to release the antibodies, which then attach to the receptors on the surface of mast cell. And the subsequent contact with the allergen causes cross-linking, which leads to degranulation of the mast cells and release of histamine and other biological mediators, which causes local and systemic symptoms. Now, the summary of action of mast cell mediators are cellular infiltration. The mediators are leukotrienes, ECF, NCF, PAF, cytokines. These called cellular infiltrations. Mediators like histamine, PAF, leukotrienes, proteases, prostaglandins cause vasodilation, increase vascular permeability. Leukotrienes, histamines, prostaglandins, and PAF cause smooth muscle spasm. With this, we end our presentation on type 1 hypersensitivity reaction or anaphylaxis.